Pelvic Inflammatory Disease, or PID, is an acute, ascending infection of the upper female genital tract. It drives roughly 90,000 outpatient and emergency room visits every year in the United States alone. A major clinical trap for practitioners is withholding aggressive antibiotic therapy while waiting for severe systemic symptoms or positive STI laboratory results. This wait-and-see approach ignores subclinical PID. This condition is defined by histologic endometritis and tubal inflammation that presents without any acute or recognizable clinical signs. Subclinical PID causes silent, ongoing scarring in the fallopian tubes at rates comparable to acute, highly symptomatic cases. Achieving clinical or microbiological cure of the acute phase removes the bacteria, but it does not reverse the physical, structural damage already inflicted on the reproductive tract. Mild symptoms mask severe pathology. Relying on symptom severity as a gauge for intervention guarantees missed diagnoses and permanent reproductive harm. Because there is no single, non-invasive gold standard diagnostic test for PID, clinical evaluation remains the definitive anchor for intervention. Standard inflammatory markers like peripheral blood leukocytosis, elevated C-reactive protein, and erythrocyte sedimentation rate have poor sensitivity and specificity for this condition. The core diagnostic threshold is this. In a healthy state, the upper genital tract is sterile. It is protected by the endocervical canal and a dominant hydrogen peroxide-producing lactobacillus ecosystem in the vagina. This barrier is typically breached first by primary sexually transmitted pathogens, historically Neisseria gonorrhea and Chlamydia trachomatis. Mycoplasma genitalium is also increasingly recognized as a primary initiator capable of disrupting the endocervix. Once the cervical barrier is compromised, the infection enters a secondary pathogenic phase. Opportunistic vaginal and colonic anaerobes ascend into the upper tract. This technical image shows the morphology of these invading bacteria. The spherical and oval cells illustrate the microscopic reality of the opportunistic pathogens driving the infection forward. This influx of secondary organisms shifts the condition from a localized single-agent STI to a strictly polymicrobial mixed aerobic and anaerobic infection. Any treatment protocol that targets only the primary initiating STIs will fail to eradicate this highly destructive secondary anaerobic flora. The most common presentation is subtle. Patients report the recent onset of bilateral lower abdominal pain that worsens during coitus or menses. Over a third of patients also experience abnormal uterine bleeding, such as postcoital or intermenstrual spotting. At the severe end, patients develop high fever, severe systemic illness, decreased bowel sounds, and rebound tenderness, indicating acute peritonitis. In about 10% of acute cases, inflammation extends to the liver capsule, causing Fitzhugh-Curtis syndrome. This presents as right upper quadrant pain with a pleuritic component, frequently mimicking cholecystitis. On laparoscopy, this perihepatitis appears as patchy, purulent exudates and distinct violin string adhesions on the anterior liver capsule.
Because these symptoms overlap with other acute abdominal emergencies, a pregnancy test is absolutely required to rule out ectopic pregnancy. Appendicitis and ovarian torsion must also be considered. The clinical spectrum of PID ranges from entirely silent to acute intra-abdominal sepsis. Consequently, the bimanual pelvic exam remains the practitioner's most reliable diagnostic tool. Acute inflammation inside the fallopian tubes causes cellular injury. It specifically destroys the endosalpinx and eliminates ciliary action. As the body attempts to heal from this inflammation, the process creates fibrosis, strictures, and complete tubal occlusion. This diagram illustrates a hydrosalpinx. The scar-blocked fallopian tube fills with sterile fluid, remaining permanently enlarged. This blockage causes tubal factor infertility. Pregnancy rates drop to 77% after 2 PID episodes and 46% after 3. Tubal damage also exponentially increases ectopic pregnancy risk. An embryo sails to pass the stricture, implanting in the wall, reaching a 1:3 ratio of ectopic to intrauterine pregnancies. Dense adhesions and tissue remodeling mean that up to 1/3 of all PID patients will develop chronic pelvic pain. These permanent physical anatomical derangements are the true cost of failing to aggressively treat subclinical or mild cases. Treatment begins with evaluating the patient for inpatient versus outpatient management.
Strict criteria mandate inpatient admission, a fever over 38.5 degrees Celsius, an inability to tolerate oral medications, pregnancy, severe nausea, or a suspected tubo-ovarian abscess. The vast majority of cases safely fall into the outpatient pathway, provided medication adherence is likely. This clinical algorithm outlines the standard outpatient backbone. It starts with a single high-dose intramuscular injection of ceftriaxone, combined with 14 days of oral doxycycline. Modern guidelines now require the mandatory addition of metronidazole to this regimen for 14 days. Clinical trials demonstrate that this anaerobic coverage significantly reduces pelvic tenderness at 30 days and eradicates endometrial anaerobes. This expanded regimen is explicitly designed to clear the bacterial vaginosis-associated flora that secondarily invades the upper tract. Standard of care dictates this 3-drug regimen for outpatients to ensure total eradication of both primary STIs and secondary opportunistic anaerobes. For admitted patients, the inpatient parenteral regimen consists of intravenous ceftriaxone or cefoxitin or cefotetan alongside doxycycline and metronidazole. Transitioning from IV to oral therapy requires 24 to 48 hours of sustained clinical improvement, marked by the resolution of fever and severe pain. All outpatient cases require a critical follow-up evaluation within 72 hours to ensure a reduction in cervical motion and abdominal tenderness. A failure to significantly improve at the 72-hour mark mandates hospitalization, imaging, and potential surgical evaluation to rule out a tubo-ovarian abscess. Clinical management extends beyond the individual patient, aligning with national epidemiological guidelines for STI control. It is necessary to evaluate and empirically treat all male sexual partners from the 60 days preceding the patient's symptom onset. Untreated partners present a severe risk of reinfection. Adolescent patients are 50% more likely to experience recurrence, which heavily compounds tubal damage. Coupling a low diagnostic threshold with broad anaerobically active therapy and strict partner management is the proven strategy to protect patients from a lifetime of reproductive morbidity.